Good afternoon, everyone. Thank you for attending Center for Vein Restoration's National CME Series presentation today. At this time, I would like to introduce our President and CEO, Dr. Sanjeev Lakhanpal, to provide more information about our National CME Series.
Thanks, Jessica. Guys, welcome again to the next episode of our National CME Series. We have an absolutely spectacular talk for you guys today. Before we get into that talk, just some reminders. Please keep your microphones muted during this process. We want to make this as interactive as possible, so the initial talk will be for about half hour. After that, questions are very, very welcome. And you can send us your questions through the Zoom link. We will try to get to all the questions during this talk. However, we also have a system set up where your CVR physician, your local Center for Vein Restoration physician, will reach back to you if any of the questions are not answered. You will receive your CME certificates. Either the physician liaison from CVR will bring them to you, or we will send them to you digitally, whatever is more convenient. And all these presentations, we are going to index them and archive them on our website. So please, at any time, if you feel one of the presentations was exceptional, go back and review them. Last but not the least, we would love suggestions on how to make this series even better. And I have an email, which is my direct email. Please do reach out, and any suggestions for that would be very, very welcome. You know, we've tried to establish the CME series, and we are learning as we are going about with two key objectives in mind. Our first objective is we want to give back to all the primary care physicians who trust us in our 90-plus centers now with their patients. And whatever we have learned during the process, we want to share with the primary care physicians, and also, secondly, with our phlebology colleagues. Ultimately, the goal being, how do we elevate the standing of the field of phlebology and also provide better care to our collective patients. A lot of gratitude to our physicians, 60 plus physicians with Center for Vein Restoration who dedicate themselves to research and to education. We have the largest fellowship program, and all this, you know, like Dr. Fernandez today and the previous speakers that we've had are all voluntary speakers from the Center for Vein Restoration. They put a lot of effort in creating these CMEs, and just wanted to take a moment to thank them all. So next, guys, I want to introduce the topic for today. During my early days of getting into the field of phlebology, when I would see some skin changes on the legs, I would have a lot of confusion. What do I do with this? Now, there's certain skin changes that are so obvious that, hey, this is because of venous insufficiency, that it's not a big deal. But there's also about 20% of these skin changes that we would come through, which are not very clear. So whether there's macule, papule, whatever, all those terminologies you learn in medical school, do I need to send this patient to a dermatologist, where there's going to be a 4 to 6 month wait before a dermatologist can see the patient? Or is there a better way for me to treat the patient right here, right now? And same dilemma is there with the primary care doctors, that do I send this patient to a vein specialist, or do I send this patient to a dermatologist? So today we have Dr. Eddie Fernandez, who is so within our Center for Vein Restoration, we have created certain subspecialties. And the subspecialty of lymphedema and skin changes, Dr. Fernandez has a special interest in that area. He got just a little introduction for Dr. Fernandez. He got his earlier degree from, the undergrad degree from the University of Vermont, then went to Tufts Medical School, finally selected the field of emergency medicine. He is board certified also in the field of phlebology. He is a professor at Georgetown University Medical School as well. So we have the honor and the privilege of having Dr. Fernandez as one of our originals here at CVR. He's been with us for more than 11 years now. So Eddie, with that, please educate us. Now I stop sharing.
Okay, can everybody see the screen? Well, everybody's muted, so I assume you can. It's the most unusual new ways in which we can bring education to everybody so we can all be in topic. Thank you, Dr. Lackapol, for the kind introduction. And I am going to talk to you about the manifestations of venous disease at the skin level, but I also want to make sure that you feel comfortable understanding what is related to venous insufficiency and what are some of the great mimics of venous disease at the skin level, which might make you question whether you should send that patient for an evaluation of the dermatologist, of pathology, or just something that you perhaps might be able to identify as benign in the office and feel that comfortable. So let's make sure that this is functioning. Okay, so chronic venous insufficiency, as many of you might be already well versed on, it is the most common vascular disorder worldwide, and in the United States, over 30 million people are affected with this. It is the most common cause of leg edema in adults, so there are extensive differential, and we'll work through that. It's commonly associated with aching, fatigue, cramping, heaviness, pain, but it also has some serious repercussions. It is the most common etiology of superficial venous thrombosis, and 25% of those patients will progress to having a DVT or will have a concomitant DVT. A patient who has varicose veins secondary to venous insufficiency also has an increased risk of developing a DVT of 5.6% lifetime risk compared to less than 1% in somebody without varicose veins. Why we're here is because there is a sequela, dermatological sequela to venous insufficiency. Varicose veins, leg edema, but there's a skin discolorations, hyperpigmentation, thickening, and ulcerations that can happen. So we know that it's the most common condition. You're going to have about 20% of the patients that come through your office having some form of venous insufficiency. Now, though they may be asymptomatic with no symptoms, that they have this underlying condition. They might become symptomatic with symptomology of pain, restlessness, cramping, but they will have some clinical signs too at times. The varicosities, and obviously the skin changes in the ulcerations and the edema. And we classify those in this CEAP category. And the most critical part is the clinical part of this, okay? It's what we're gonna be observing on our patients. Behind that is gonna be the etiology, what we're gonna try to find out, and obviously where in the anatomical a component this is arising from. It's the superficial system, the deep system. Where amongst those systems it might be the pathology, and obviously what is the pathophysiology behind it, primary, secondary to a DVT, trauma, etc. So what are the mechanics of venous insufficiency, and how is it that we get to this dermatological manifestations? Well, it all starts with very simple mechanical malfunction of venous valvular system, which allows the reflux or abnormal flow of venous blood into the lower legs. Now, it is a pressure problem that translates all the way to the capillary system, and hence why we see this condition arising in the gator area predominantly. And as this depiction shows you, that's where you start seeing the majority of your varicosities, skin discoloration, ulcerations, edema, etc. So what are some of the skin manifestations and how common are they? Well, we start to see them mainly in the middle-aged to elderly patients. we see them in patients with acquired venous insufficiency due to surgery, trauma, or thrombosis. There's a slight preponderance into the female population, and the etiology of all of this is still evolving. There are a lot of hypotheses out there. There is some strong supportive hypotheses that there is an impaired clearance of cellular metabolites and damage to the lymphatic system, sort of a hyperinflammatory response that occurs. But that's all still being worked out. Your patients will present with pruritus, okay, that is fairly typical, often leading them to get to scratching. This could be a portal for infections or even for the ulceration. The discoloration that can start to evolve, again, predominantly in the gator area, ankle area, and often associated with this edema as the most common cause of edema. And this is sort of what we start to see in our patients. Now let's break this down in the CEAP category, okay? We have broken it down into seven steps, with CEAP 0 being no visible palpable signs of venous disease, and then 1 through 6, which we're going to break down into more detail. Here's CEAP 1, which are your telangiectasias, also known as spider veins. These can come in two flavors. As I like to tell my patients, they are sort of essential spider veins, which are really benign, more cosmetic, commonly seen in the lateral aspect of the thigh. But they can also be the first indication that there is a more significant problem with the superficial or deep system. These are nothing more than dilated postcapillary venules associated with that backflow from incompetent reticular feeder veins. Okay? They are at times connected to the superficial or deep system. Okay? And as I already mentioned, not all of them are necessarily secondary to venous incompetence. But here is something that we do see frequently in our patients, especially in our older patients. This is corona fluidica, okay, or your venous crown that starts presenting in the medial or lateral malleolar region. And it was first described in the 1960s. It's a fan-shaped set of telangiectasias, and there is a strong correlation with the venous insufficient component of the great saphenous vein, of the small saphenous vein if it's the lateral malleolar region, or the deep system at times that the patient has a history of thrombosis or pelvic iliac compression. That can also present, this be the earliest presentation of this. But there are things that can mimic this. We always have to think about medications and drugs that can lead to many of the conditions that we can see with venous insufficiency. So I always make sure to review the patient's pharmacology and make sure that they are not taking any medications which might lead to some similar presentations. And here we have minocycline, a side effect which is not uncommon, and it's a hyperpigmentation that can occur with minocycline. A perhaps more common thing that we can see is lipidoid reticularis, okay? And these are sort of broken down into different parts. So lipidoid reticularis can form in the form of cutis marmorata, which is just physiologic. Patients exposed to cold weather, it's variable. They can be born with this. This is often seen in infants when they're born and they outgrow this, and we don't think much of it. This could be significant, however, of things like sepsis and other more generalized conditions. So we have, when we see this, we have to take a look at a little bit more in depth about the history, the presentation, how long this has been present, the location of it, and then try to assess whether there is a more serious component. So these patients often, we see them frequently in the lower legs, but when we see them in the lower legs, sometimes if you look in their forearm and upper arm, you will see some presentation of this lacy kind of pattern of spider veins. And most frequently, when we're seeing these patients in the office, thankfully they're not septic or that sick, they're not infants anymore. And the majority of them just have this physiological component to it, more frequent with different exposures to temperatures. Sometimes medications can do it. And it's most frequent, obviously, in fair-skinned people. Now, the next step is CEAP2, which is our varicose veins. Pretty straightforward. Varicose veins are nothing further than our little tributary reticular veins. They're the soldiers which are under stress. I call them the tip of the iceberg. When you start seeing varicose veins, there is some form of damage to the venous system. And these veins are slowly getting dilated because of that pressure. They get thickened because they need to handle that pressure. If not, they burst, and we do see them as subcutaneous hematomas secondary to that pressure, or they just slowly erode through the dermis and they bleed. Most commonly, you get this story of this patient's getting in this warm shower, and next thing they're having a spurt of blood coming, usually from the lower leg. And this is a common presentation, unfortunately, in this case of a male, and this picture is very valuable for many reasons. Number one, I hope it brings the point across that this is a predominant not just in females, but in males. It clearly has a significant effect on a patient's quality of life. This is clearly not a cosmetic issue, and this is very much a response to an abnormal venous component. And once you treat it, you can see that it's just nice resolution of those varicosities, and as well as avoiding further complications from this disease, such as superficial thrombophlebitis. Again, 25% of these patients will progress or have a concomitant DVT. In this case, the markers are already here, but all of this is thrombose. And this is an unfortunate woman who you can already start seeing an ulceration associated with this condition. So not only did she develop the complication of superficial thrombophlebitis, but she already has hyperpigmentation, which we're going to talk about, and the ulceration associated. And again, proper treatment of the condition leads just within a month to rapid resolution of the ulceration and obviously relief of the pain associated with the thrombophlebitis and the other risks associated with the disease. Here is a big mimic presentation of varicosities. I see this all the time, and this is a totally fair referral for evaluation of venous insufficiency. And it is nothing more than tibialis anterior muscle herniation. And you see in this picture, I picked this picture because it really depicts clearly some of the small reticulars, borderline varicosities that you might see in the anterior tibial area. But then you see this large protrusion. And these feel buggy. When you touch them, they feel just like a varicose vein. But the one key feature of this tends to be symmetrical, usually in the area that you're noticing here in this image. And if you ask the patient to dorsiflex or plantar flex, you will see these herniations appear and disappear. And you there have your diagnosis. This is a benign condition, can be associated with trauma. It can be surgically repaired if the patient wishes, but it can be just left alone. When you read about this, you see a lot about the aspect of trauma causing these herniations. However, I see a lot of this symmetrical, which leads me to believe that there is a genetic embryological component to this. in which they appear that symmetrical pretty much about 90% of the time. So we talked about how venous insufficiency is the most common cause of lower extremity edema. And this is secondary to that venous congestion that leads to our varicosities, but it also leads to increased capillary filtration. This adds further stress to the lymphatic system and will eventually lead to what we now have coined fleval lymphedema. Unfortunately, once you get to that stage, total resolution of the edema is not always possible. Always talk to our patients about about 25–50% improvement in their edema, but you want to avoid getting to that stage, and the earlier identification of that swelling, it's key to trying to provide the patient with the best results post-treatment. But when we look at edema, it also has other etiologies. And I like to break it down as bilateral edema or unilateral edema. And when I think bilateral, I start thinking systemic issues. I start thinking of allergic reactions, cardiac, renal. Medications are very important, very commonly seen with calcium channel blockers. Fantastic medication for blood pressure control, but also has a significant association with edema. Does the patient have hepatic issues, nutritional problems? Pulmonary hypertension, another very common cause of lower extremity edema. And in young people, and females, in this case, premenstrual edema that is seen usually in the perimenstrual period. When we're talking about unilateral or localized edema, we have to think about infectious etiologies, lipedema, lymphedema, iliac venous compression, which is an outflow obstruction of the deep venous system. Obviously, DVT. All your patients should be getting an ultrasound to exclude a DVT, and in rare cases, obviously, compartment syndrome. But unilateral local edema, if you don't have any of these categories, it is venous until proven otherwise. And these patients will benefit from having an ultrasound performed. Unfortunately, as the disease continues to progress, we already talked about edema and how it can be permanent. But then we develop other more concerning issues such as eczema and hyperpigmentation. And many of these changes are permanent and they won't improve even after treatment, though we will stop them from getting worse. So venous eczema is the earliest cutaneous manifestation of venous insufficiency. And it looks just like any other eczema, except that you're going to obviously see it in the lower gator area. The medial ankle is the most common because the great saphenous vein is the most commonly affected vessel. But you can see it in the lateral aspect of the foot, as you see in this depiction, associated with the small saphenous vein disease. It is just the classic eczema changes with erythematous, scaling, and exudative weeping patches and plaques. The hemosiderin deposition comes next, and this is as those frail capillaries start to break and deposit blood into the area, you have hemosiderin deposition into the subcutaneous space, pretty much, unfortunately, tattooing the patient. And then as this all continues to progress, that chronic inflammation will lead to fibrosis, which we're going to talk about next. But here are some of the other things that you have to consider with hyperpigmentation. It is cellulitis, okay, usually unilateral. It is acute, it is painful. What are the symptoms that are associated with the patient? Is the patient having other systemic symptoms? Contact dermatitis usually tends to be a well-defined borders, more acute. There is more pruritus than pain. and there's some kind of causative agent, which makes that diagnosis a little bit sometimes easier to do. Then lymphedema, and you say, well, lymphedema is just swelling of the leg. Well, unfortunately, as lymphedema progresses, you will start to see skin inflammation and fibrosis and pigmentation. So again, you can be just having primary lymphedema or secondary lymphedema, or you can be having fleval lymphedema. So you do want to always think about venous disease in a patient with lymphedema in hyperpigmentation. And obviously venous thrombosis, whether it's superficial or deep, in the superficial, as you saw, it can have some very clear signs of hyperpigmentation, inflammation associated with it, but so can the deep thrombosis. Here is another big mimicker that we see very frequent in hyperpigmentation, and is Schamberg's disease or purpura pigmentosa progressiva. This is a chronic discoloration. It is hemosiderin mediated, can be present in all ages. I see them more frequent in males, and it is of the lower legs. The key part here, it is that it's symmetrical, and I often see this into the dorsum of the foot and into the dorsum of the toes. So if you're seeing a very symmetrical hyperpigmentation on a male, it's not painful, it's not pruritic, start thinking whether this should be Schamberg's. You can always get the ultrasound, exclude venous component out of this, but then we have our diagnosis. And again, this is just benign, slowly progressive, but it's of no real pathological issue to the patient. This is also extremely common. Unfortunately, just as diabetes is common in our society, so is diabetic dermopathy. As this patient's progressing their diabetes, and I apologize if the image is not better, but this is one of our my patients, and this is a very symmetrical, but it's just over the shin area. But again, the key part here is the symmetry. They refer them as diabetic shin spots. Is more present as we age, greater than 50 years of age. It does have a significant correlation with coronary artery disease. I think whether the way I visualize it, I don't know that the development of the hyperpigmentation or these diabetic shin spots is a marker for coronary disease. I think it's just a matter of how chronic the condition of diabetes has been in that patient to the development of the shin spots. Obviously, with chronic diabetes, these patients are more likely to have coronary disease, and I think that's really is just not a direct but an indirect manifestation. Static eczema is something that, just like any other eczema, can be confused with venous stasis eczema, but it is more frequent in the lower extremities. But the key thing here is that it's present mainly in the elderly. Unfortunately, venous disease becomes more frequent as we age, and obviously we might need to get that ultrasound to exclude whether venous insufficiency is correlated with this static eczema, or is it venous eczema, or is it just static eczema? It's all not just in the winter months like every other eczema, but it tends to be also associated with some dehydration, which tends to be common in our elderly population. This is not as common, but I've seen a couple of them. It's just a deep folliculitis, predominantly in females, from shaving, and obviously as it's more frequent in the summer months, humidity, more frequent shaving, and you can start to see this Mayoki granuloma, and I apologize that I'm mispronouncing it, but that's how I refer to it. Very common tinea pedis, which again, another dermatophyte, but it can present with pruritic, scaly, painful fissures, and depending on their location can be confused with venous stasis, ulceration, and hyperpigmentation. And finally, discoid eczema. Now, discoid eczema is, you see it mainly in the older population. The key thing is you're going to see this round disc that are classic appearing of eczema. Again, they have they're pruritic, they're scaly, they break down. The etiology of discoid eczema is not clear. However, there is a correlation with venous insufficiency. And patients with venous insufficiency, that reactionary pathology, the venous insufficiency might be the catalyst. So you do see patients with this discoid eczema, the lower extremity, whose trigger is the venous insufficiency. So again, a patient with discoid eczema, the lower extremities, if they might have it in the upper extremities, at that point you might start thinking that there's other kind of exacerbating factors such as caffeine, heat, so on. But if they're in the lower extremity alone, I would consider venous insufficiency, especially if that patient is older, that patient has other signs or symptoms associated with venous insufficiency. Finally, we move into what CEAP4B is a subcategory. So CEAP4, we break it down in the A and the B. And the B is very specific to the lipodermatosclerosis and the atrophy blanche. But this is the lipodermatosclerosis in which now the inflammatory processes have caused not just increased pigmentation, but now you're starting to get the induration and fibrosis scarring. This happens similar to what we see with chronic lymphedema, in which these patients also get fibrosis and scarring. However, the lipodermatosclerosis has a very pathognomonic presentation of this inverted champagne bottle or bowling pin. And you can just see it in this image better on the right, lower extremity than the left, but they both have that inverted champagne bottle appearance. The skin is hard, it's very friable, it's often inflamed. They often get confused with recurrent cellulitis. So if you have a patient who has been now on multiple rounds of antibiotics because they keep getting this recurrent cellulitic kind of presentation to the lower extremities, you might want to consider that this patient has venous insufficiency and evolving into this C4A hyperpigmentation and lipodermatosclerosis. But as I mentioned, it also has this atrophy blanche. And unfortunately, this is just your precursor to an ulceration. It is a type of dermal scar tissue. Okay? It's just like we know that any scar tissue is weak and friable, this is no different. It is an obstruction of dermal arterioles. There is associated infarction of the skin supplied by these vessels. And they, as I mentioned, they are very prone to ulceration and necrosis. If you have a patient with this, you must have them be evaluated for venous insufficiency. This might be just what the presenting step prior to getting an ulceration. Now, atrophy blanche, it's confusing part. You can also see it with other conditions such as lupus, rheumatoid arthritis, livedoid vasculopathy, and Klinefelter syndrome. However, the most common cause of atrophy blanche is venous insufficiency. And here we have classic presentation of livedoid vasculitis. As you can see, very similar anatomical location. They leading to persistent painful ulcerations, okay? They're primarily exclusive to the lower leg or foot, more frequent in women. The incidence of ulceration is more frequent in the summer months, okay? It tends to be associated with the Raynaud's phenomenon and acrocyanosis, as well as other thermophilic abnormalities. So if we have a patient like this, personally, I would get an ultrasound. It's the easiest, least invasive. If the ultrasound does not give us an answer for this, I would start looking further as to what other conditions may be leading to this patient's presentation. CEAP is what we refer to as a healed ulcer, okay? And there's not much to go into this category, but we have put this category, when the CEAP categorization was described, CEAP became before active ulcers. So a patient can go from CEAP to 6 with an active ulcer, or CEAP to 6, and then once the ulcer's healed, they go back down to a 5. Unfortunately, a patient, once they have a healed ulcer, they will never drop down in the CEAP categorization system, which is one of the weaknesses of the system, and what we use other categorizations to better graph the progression or improvement of the patient's condition as we treat their venous insufficiency. But the key thing that I do want to drive is that these ulcers healed very well, like when you take care of the underlying etiology. I always tell my patients that I'm not the healing agent as much as I am the assistant to their body to heal itself. The body wants to heal itself if you provide it the right medium. So in this case, the images on your right are of a young female in her mid-30s with 2 years of ulcerations. And you see classic venous ulceration. And the picture below is 4 months later after treating her venous insufficiency. Gentleman on the left, it's a sad case because he had this ulceration for, I believe it was 7 years. Unfortunately, took good care of it himself, but he had no insurance. But this is what he walked around for 7 years caring for that ulcer. The image you see on the left is within 3 months of treating his venous insufficiency. Just rapid healing. Once the body was provided with the appropriate milieu for it to heal, it will heal itself. But active ulcers are an unfortunate part of this condition, and unfortunately, they are very common. They're classic because they tend to appear in the distal third of the tibia and perimalleolar area. Depending on the vessel affected, it can be medial or lateral. They are very painful, okay? Any debridement of it, they tend to be vascular, so they will bleed very easily. I think this is one of the benefits. That's why they heal also so well once you take care of the underlying condition. It's just a lot of granulation tissue. The edges tend to be erythematous, they're inflamed, and they're elevated and hard. But they are unfortunately the commonest form of ulcers, and this is nothing that any of our patients should get to. We should have identified a lot of the symptomology and signs associated with venous insufficiency before a patient gets to this stage. But it's good that we can easily help them. As I mentioned, they are very common. It affects about 1% of the total population and about 20% of those patients with venous insufficiency. Once they do occur, these patients unfortunately undergo a prolonged therapy, often associated with wound care. They're not always first identified as it being venous related. They have a huge socioeconomic impact. Okay, they impair the ability to engage in social and occupational activities. They have a horrible reduction in the quality of life. There's a significant level of depression, physical dysfunction, immobility, and social isolation. There's loss of productivity, okay, and obviously early retirement. The financial burden on the healthcare system is also huge, about 2% of the total healthcare budget in the United States. is associated with management of these ulcers. And this is further of the physical exam that we should use to differentiate ulcers. The location in this, you guys, all of you will have this presentation, so you can refer this back to this. Obviously, whether it's a gator region versus more proximal, and the foot not as commonly venous associated. The skin surrounding the ulcer can be very directive to our diagnosis. If we have some lipodermatosclerosis, often there is associated with venous disease. Atrophy blanches we discussed could be venous versus vasculitis. Atrophic skin changes, you have to consider arterial other conditions. The edge of the ulcer can provide further information, as well as the base of the ulcer. And this is obviously what we fear the most is arterial ulcers, because obviously, unfortunately, they do lead to limb loss, but thankfully they're not as common in the population. So the location is very different from our venous ulcers. Their appearance is very different. They tend to be dry, punched out, not as painful. Hopefully we can differentiate this already just in the physical exam. And mentioned there are other forms of ulcers. So venous ulcers are the most common, and then arterial. You can also have pyoderma gangrenosum, necrobiota lipotica, common ulcers of the diabetics. We can never forget about cancer, and cancer can coexist in many of these ulcerations, whether it was the primary agent or it is secondary to the chronic inflammation associated with these ulcers. This is one study from 2004 that shows how well these ulcers do when you provide surgical management as well as compression versus compression alone. The key part is that these ulcers heal about the same. However, patients do better in the long term. The recurrence rate is lower at 12 months, at 4 years, at 3 years. So this is a very supportive of why we should be treating these patients early on, fixing the underlying condition of venous disease. So if I'm going to bring you back to something that I hope I've made very clear, is early identification of the skin manifestations of venous disease hopefully leads to early management of the condition and preventing a cascade of negative effects. So those patients with varicose veins should be identified early. They should be educated that this is not a cosmetic condition as many of them would think, and we have thought decades ago, but that this is just the tip of the iceberg. And untreated, this leads to this swelling that we see, which often leads to frequent DVT scans for rule out, primary care visits, often unnecessary medications such as diuretics, CAT scans, blood works, and obviously new shoes if you cannot fit in that. As the skin damages progress, obviously can lead to dermatological visits, irreversible damages as we have discussed, pre-ulcerative and ulcerative changes, as well as pain. And finally, unfortunately, the ulcerations, the wound care, the unnecessary antibiotics, or at times necessary because of secondary infections, and the impact in the patient's quality of life. I'm going to leave you with an atypical presentation of a patient that had squamous cell cancer. I touched briefly with ulceration about how we can always must have cancer in our differential. whether it's basal or squamous. And this gentleman had squamous, underwent both resection and then radiation therapy. After the radiation therapy, he was labeled as a radiation ulcer. He underwent 2 years of wound care that included hyperbarics. He had 3 vascular surgery consults in which he was labeled again as this was just a radiation ulcer and nothing that could be done for the patient. Finally, when I saw the patient, we saw some of the surrounding tissues as well as his other leg. So when you started to focus on the other leg, which is a little bit off image, but he had hyperpigmentation. He had some early fibrosis. He had eczema of that right leg, and he had all the associated changes on the left leg. When we did the ultrasound, what we found was significant great saphenous vein disease, and as well as an accessory vein leading right into that ulceration. We treated the venous insufficiency both with thermal modalities as well as ultrasound-guided foam sclerotherapy technology. And you can see at 4 months almost near complete epithelialization of his ulceration. So I think this is this is a great case because you don't know whether the ulcer and the vascular damage surrounding that ulcer was made worse because of the radiation ulcer. Radiation, though they try to avoid collateral damage, will have some injury to the surrounding tissues and vasculature. It is not immune to this. Or was the problem already there, and once he received the radiation ulcer, that was the trigger, that traumatic trigger that often patients will have that leads to further ulceration. I think in this case, because of his findings in his other limb of venous insufficiency with significant changes, I think his primary problem was venous insufficiency, that the radiation therapy just led to the ulceration of that area, and it would not allow it to heal. So I thank you so much for your attention to this presentation. I know that Dr. Lackenpaul is going to now moderate some of the questions I'll be happy to answer. I do want to let you know that there's an upcoming webinar with Dr. Stewart. He will be talking about leg pain and chronic venous insufficiency. That will be on Friday, July 31st at noon. I hope you enjoy this presentation, and I'm happy to open it to any questions.
So Eddie, thank you very much. I mean, this was an absolutely spectacular presentation. I mean, you've covered everything from CEAP1 all the way up to venous ulcers, and we've got some good questions here. But before we go into that, I just wanted to ask you a little bit on the worst of the skin changes, which, as you mentioned, are ulcers. And you know, you bring out that point that most ulcers, up to 70%, are venous. Somehow we all feel when we think of an ulcer, it's going to be an arterial ulcer, but venous ulcers are so much more common. And it's a shame, as you pointed out, that still 1% of the population. And if we look at the elderly, if you look at 80 years and above, almost 3% of our octogenarians are walking around with venous ulcers. It just shows that, you know, we need to be able to identify a venous disease at a much earlier stage and treat it. However, the fear when you're dealing with a chronic venous ulcer always is, or a chronic leg ulcer is, am I missing a malignancy? What is your protocol? When do you start looking, hey, is this a malignancy and do I need to do more?
Okay, so I take, that's a great question. Thank you so much. I think and what I do in every patient is the history is critical, then the examination. I think that we have a privilege in Western culture that we have every test and technology available at our hand, a snap of a finger. But we cannot forget how important that physical examination is. You have to really make sure that your physical exam matches the need for any imaging, in this case ultrasound most frequently, and that the data that you're getting back matches your physical findings. Let me explain. If I have an ulcer which has irregular borders, an ulcer that has necrotic areas, an ulcer that is rapidly progressing, an ulcer that started with smaller skin changes and the surrounding tissue seems very healthy, and the patient has no other symptomology of venous disease, I get concerned whether there is malignancy. I recently had a patient sent to me for evaluation who ended up with a basal cell carcinoma, that was just ulcerating, but the borders were very irregular. The skin surrounding the lower gator area was fairly healthy. She did have some small reticular spider veins, which is why she was sent to me for further evaluation. But the ultrasound did not demonstrate any significant venous disease. So you have to make use of all of the data that you have to give you support, and you cannot ignore that physical exam. The stuff that we learned back in medical school, some of those basic skin changes that we see with malignancy, have to keep you awake at night, and at that point, I get him for a biopsy. Also, after treatment, if you saw that case, a patient had concomitant disease, he had squamous cell carcinoma, he, I think, had a venous insufficiency also at the same time. Had he presented with an ulceration as his first presentation, and we had treated it, as we follow the patient, you can see the response. And it's a lot of experience after over a decade of seeing how these venous ulcers present, but also how they respond to treatment. You can see that you would see that, hey, this is not really progressing as they should. There's something different about this, even though this patient had the venous insufficiency, everything, all the cards were sort of very clear. There's something else. So you should always have your level of suspicion high. And that's how I approach that patient.
Thank you. And we have a great question here. This is from Tiffany. Do you have any of these disease? How do these disease manifestations differ in patients of color? And we have a lot of experience in that. I mean, most of our clinics, or a lot of our clinics, do serve the minority populations. So how should hyperpigmentation or hypopigmentation in some, how should that be viewed?
So some of the earlier pigmentary changes may be hard to elude in patients with darker skin tone. However, the other physical characteristics are fairly clear. When we look in, even if you don't have any varicosities, which are fairly clear cut, but if you start to touch the patient, when I tell my staff, always touch that patient, touch that area of concern. How does it feel? The patient's having pain in a location. Is it indurated? Is there a boggy component to it? Sometimes varicosities cannot be clearly seen, but they can be felt. So as you palpate around the area, you see that. Unfortunately, in our population, because we do, as Dr. Lakenpohl elucidated to, we do treat a large minority population. We see a lot more significant severe disease. We see a lot more of that ulceration. That is either because they have lack of access to the healthcare system, but they also have jobs that are higher risk. They're on their feet. They are working 2-3 jobs at times, spending 16 hours on their feet. So they have a other physical, environmental proponents to the development of this disease. But once they develop into the more advanced disease, they're not presenting any different. Early on, they can make it harder.
And hyperpigmentation. So once a patient comes and you completely are sure that this hyperpigmentation is due to venous insufficiency, you've treated the patient, what else can you do? I mean, so many times you have a young lady or a middle-aged lady who is or a gentleman, who are very concerned about their appearances. How do you help with the hyperpigmentation beyond treatment of venous insufficiency?
So my first step to that's another great question, because hyperpigmentation is so significant to so many of our patients. It's what the world sees. And many times, as I mentioned, it becomes something for which they feel isolated from the world because they're ashamed of what their legs look like and what other people may think that they have, what kind of medical condition do they have, are they contagious, or so on. But hyperpigmentation, unfortunately, is hard to treat. Once the hemosiderin deposition happens, it tends to be permanent. Now, with that said, I tell all my patients to expect no improvement, resolution of the hyperpigmentation, but to expect some improvement. How much is that improvement going to be? It varies a lot. It varies on how long they've had the condition, how advanced it is, just like anything else. The further along, the harder it is to reverse the changes. Their skin pigmentation will play a role. Those with darker skin pigmentations will have either hypopigmentation from the scar tissue, as you saw in that image, which we can reverse. Or they might have some hyperacute presentation of the hyperpigmentation. They do get some resolution. I never promise 100% resolution, but as that inflammatory process is eliminated, their body does heal. It can take upwards of 2 years. With that said, I always promote good skin moisturizer to keep the skin healthy. And I have my preferences that I provide those patients. Some of the patients will like to try hydroquinone cream, bleaching skin cream. It really does not work well. It's not my experience. It's usually not covered by insurance. It's not cheap, and it really does not provide a great improvement. And they can, if they're really still bothered by it, we can get them to a specialist in lasers who can then address that using lasers like they do for tattoos to help with some of this hyperpigmentation.
Thank you. One more question we will take since we have a couple of more minutes from Sarah Mahmood. It's in residency, we were taught to get baseline non-invasive vascular studies prior to beginning compression therapy. And in patients with CHF, we were taught that compression was contraindicated. How would we tackle the edema problem in that patient population? So in other words, patients with compromised arterial flow or with CHF.
Great question. That's something that we take into consideration with every patient we see. I will tell you from the arterial side, if I have a real concern that this patient has arterial component or a mixed a pathology present, which it coexists, I will get them for that vascular arterial. I do not get every patient an arterial exam before I put them in compression stockings. But if that patient has the risk factors, age, smoker, diabetic, they have skin changes in the lower foot, cyanosis, a decreased pedal pulses, I will add that. With that said, it's very unlikely that you will do harm with compression stockings in most people with arterial disease. I think unless
it's really severe. Yeah.
Yeah, exactly. Unless it's really, really severe, and I think at that point it'd be very obvious that the one unlikely to do harm. With that, I would still do the vascular study. Now, the patients with CHF that have that edema, I do want to know their cardiac function. I want to make sure that I'm not going to send them into overwhelm their cardiac system. So I am aware of that. I have occasionally a patient that will come to me in which their venous exam does not match the condition. We think it could be cardiac, or they have the history of cardiac disease.
Yeah.
I will talk to their cardiologist and get an echocardiogram, see, and then we can start addressing that edema. If the edema is a mixed edema, some cardiac components, some venous or lymphatic, it's a little bit harder to manage because, again, you do not want to stress their heart, but that's something that you do in collaboration with the cardiologist.
So Dr. Fernandez, a great point to end at. Dr. Mahmood, it's, you've always got to treat the patient in their entirety. If there is coexisting arterial disease, then we've got to see what is the easier to treat out of the two, so that our ultimate goal is to improve the perfusion pressure. So either you can help by decreasing the venous back pressure or enhancing arterial pressure. And, as an organization, we take pride in treating our patients in their entirety. Again, Eddie, a fantastic talk. Our 1 hour is over, so respecting everybody's time. Some of the other questions, guys, that have been put forth, we'll make sure that our local CVR physician will reach out to you. Please do register for next time's talk. This is going to be more of a clinical talk. How do you separate leg pain due to chronic venous insufficiency clinically from leg pain due to other reasons? We're really trying, like I said earlier, hard to have topics which are relevant for both the primary care subset and the phlebology subset. Dr. Stewart is an amazing speaker. Look forward to seeing you guys next time. And Dr. Fernandez, once again, thank you very much for an amazing talk.
Thank you, Dr. Blankenwald. Thank you, everybody, for taking time.
Thank you, everyone, for attending this afternoon. Please make sure that you also fill out the survey so that we can ensure that you have your first and last name correctly sent over to us for your CME credit. Again, please make sure you register for the next presentation, and we appreciate everyone's time this afternoon. Thank you.